Okay. Thank you, sir. Should I share my screen first, no?
Yeah, first you have to share, Prashant.
Yes, sir, yes, sir, yes. I will allow sir to be your host.
Yeah. Host disabled participant screen sharing.
Yes,
It means that.
Yeah, sorry. I think
Now,
the connection
you
got
the
lost.
Okay.
So all the mic, the stage is all yours, Dr. Vipul. Go ahead, and we will all listen to your experience.
Okay.
Sir, you can start your sharing, sir.
Okay, fine.
Yes, sir. I will stop sharing, sir.
Okay. Yeah. Now, is this visible now? My slides?
Yes, sir. Your slides are visible, sir.
Okay. Very good evening to all of you. And thank you very much, Chairperson, sir, for the introduction to the topic. And before starting my deliberation, I would like to sincerely congratulate the Endocrine Society of Bengal for keeping the spirit of education in these tough times. So before starting only, we talked about COVID situation in Kolkata and in Assam. Our SRs are also doing duty. And in this tough time, doing the academics is actually a tough one. And I congratulate Endocrine Society of Bengal for that. And also thank the society, particularly Nilanjan sir, for giving me this opportunity to interact with DM resident students of West Bengal and others. So we are going to discuss this entity called the cyclical Cushing syndrome. As Bandgar sir has already said that there may be some variants like mild Cushing's, or there may be cyclical presentations of Cushing syndrome. So this is one type where you need to have a lot of clinical suspicion to detect cyclicity of this condition. I'll start with two cases which I have taken from the leading journals to just have an idea on how cyclical Cushing present. Then I'll go to a little bit of historical aspect, how this entity came into being. Little bit of basics will recapitulate, where we'll just recapitulate and see how it affects Cushing syndrome, the normal hormonal rhythms and all. Define what is cyclical Cushing's, then go to the prevalence and etiology of cyclical Cushing's, and discuss what are the various mechanisms or pathophysiology which has been described to define cyclical Cushing's. Then discuss about the clinical features, its differential diagnosis, how to evaluate and treatment of the condition. So let me first take you through the case number 1, which was published in BMJ case reports in 2017. Now this is a 68-year-old male with 2 years history of diabetes mellitus with hypertension, and he was referred to endocrine clinic for evaluation of a possible adrenal insufficiency due to his symptoms of episodic muscle aches, extreme tiredness, and generalized skin pigmentation. He also complained of polydipsia, nocturia. There was difficulty in climbing the stairs, but there was no history of any weight gain. His symptoms were intermittent and occurred at least twice a month. This was cyclical. And during that time, he would have myalgia. It was difficult for him to walk, and his blood glucose levels were also fluctuating. A biochemical workup done prior to his referral showed that there was a normal short synectin test, because this patient was thought to be having adrenal insufficiency, and he passed the short synectin test. The pituitary profiling was also done. All the pituitary hormones were normal with a normal LFT and KFT. And in examination, he was hypertensive. There was diffusely hyperpigmentation, and he had prominent pelvic girdle muscle. but the typical phenotypic features, the Cushingoid habitus and all were not there. In this endocrinological clinic, in view of this proximal muscle weakness and increased pigmentation, they did a screening test for Cushing. And it showed a high 24-hour urinary free cortisol level of 573 nanomole per day. Then a ONDST was done, which was not suppressed, and ACTH was elevated on 2 occasions to 48 and 98 nanogram per liter. Now, because there was intermittent symptoms and there was absence of any significant phenotypic feature of Cushing's, this patient underwent a series of 24 hours urinary free cortisol assessment. As you can see here, that on different days, his urinary free cortisol remained higher than the reference range, but on a particular day, which was quite high. On that day, the same sample was also re-verified in a different laboratory. It was found to be high. So there was no interference as such. Now, in view of this fluctuating hypercortisolemia, it was decided to measure daily late-night salivary cortisol levels for this patient and also to record his symptoms and maintain a diary to confirm whether there was a cyclical pattern of cortisol secretion and whether these symptoms were related to any cortisol spikes. And they could find, as you can see here, that every 7 or 8 days, there was a spike of salivary cortisol. So they labeled this patient as a case of cyclical Cushing's, and further investigations were done. I'm not going into details of that, but this is a typical case of cyclical Cushing's, where you get biochemically there is increased cortisol levels, but clinically this patient was not overt type of Cushing's. Rather, this patient was referred as a case of adrenal insufficiency. I'll come to another case. This case was also published in a journal JCM in 2004. This is the case who showed rapid changes in body habitus over 3 years. Now, this child was born at 35 weeks of gestation, and after birth, she had some ethnic spills and hypothermia, for which she was put in a neonatal ICU. On day 3, it was found that the child developed hypertension, 140/90, and the clinicians also noticed some plethora, some edema. So they did a cortisol level, it was quite high. They did a ACTH, it was suppressed. They also ruled out pheochromocytoma, and then this child was managed with diuretics as well as beta blockers. Then after 3 weeks or so, this child was discharged. On follow-up, it was seen that by 2nd month, this child's hypertension was almost recovered. Child was off medication, and the facial plethora, the puffiness, that also went. Then this child remained asymptomatic for next 1 year and 1.5 years or so. Then at the age of 2 years, this child's parents noticed sudden weight gain. She had voracious appetite, there was some hypertrichosis and some facial plethora. But due to some reasons, the parents could not bring this child to the clinician, and almost a month or so had passed. By the time they reached these features, this weight gain and all, that had subsided. And the clinician found that her cortisol level this time was normal. Actually, no features. Yeah, typical. Hello. Pooja, please. Yeah. So there was no features of any Cushing syndrome. Then this time, parents were educated and they were told that as soon as she develops such features, they have to come to the clinician. Then by the age of 2 years and 11 months, by 3rd year, she again developed these features of Cushing syndrome, and this time they came to hospital and she was diagnosed to have again Cushing's typical Cushing syndrome biochemically. So as you see here, this is also a case of Cushing syndrome cyclical variety. So she had 3 cycles of typical Cushing's which lasted for just 2 to 3 months and then recovered by its own. So you can see these are 2 different cases, one elderly which didn't have any typical features of Cushing's but had biochemical cyclical Cushing's, and here this is a child who had developed cyclical Cushing's with all overt features of Cushing's over period. Now we'll be discussing this Cushing's, cyclical Cushing's. Now let us go into the historical aspect of Cushing syndrome. Actually, this is not historical aspect. I'll show you over time how this entity came into being. So some 50 years back in 1956, probably the first case of cyclical Cushing's was described. At that time, it was an unknown entity, but Bark et al. He found a patient and he of Cushing syndrome, overt Cushing syndrome, and he measured the excretion of 17 keto steroids and 17 ketogenic steroids over a period of 40 days. And he could find that there was cyclical increase in these 17 keto steroids. And probably this was the first case of reported first case of cyclical Cushing. But the credit of defining cyclical Cushing's goes to Bailey. He, in 1971, described a patient in whom he very carefully, meticulously estimated the 17-hydroxycorticosteroid over a long period of time, and he could show 2 peaks and a trough of hypercortisolemia. And this Bailey is credited with defining this new phenomena called the cyclical Cushing's. Then the next important case was described by Brown et al., where in the case of Cushing syndrome, he found that after dexamethasone suppression test, there was a paradoxical rise in cortisol level. And to further investigate the cause, he did the urinary 17-hydroxycorticosteroid, the keto steroid for this patient over a period of 100 days. And he could find that there was a cyclical pattern in increase in this cortisol level and urinary metabolites. And this unshaded area was when he did a overnight DEXA suppression test. It was high, and he said that this is nothing, this paradoxical response is nothing but de novo increased secretion because of this cyclicity. Later on, in 1973, Cedar Bark et al., they did an important study where they compared 3 normal subjects with 7 patients of Cushing syndrome, all with different etiology. And they saw the concentration of plasma corticosteroid. They estimated it every 20 minutes for a period of 26 hours. And it was found that in all patients of hypercortisolism, the plasma corticosteroids were elevated, and they clearly differed in their rhythmicity for normal. So they were the first to say that cyclical Cushing syndrome can have different type of etiology. Now let us come to some basics of Cushing syndrome. Now we all know about the hypothalamic pituitary adrenal axis, how the CRH stimulates ACTH and adrenal secrete cortisol, what is the negative feedback to the pituitary, to the hypothalamus, what is diurnal variation or rhythm. There are various factors. Apart from these stressors, there are factors like GABA, there are factors which like norepinephrine, which controls HPA axis. We also know the rhythmic secretion of cortisol, and in normal individual, both cortisol as well as ACTH, there is a diurnal variation. That means in the morning hours, you get the maximum secretion of cortisol, and at midnight or so, you get the nadir. Now, this is called the diurnal variation or the rhythm. Besides this, there are two more rhythms. One is the ultradian rhythm, which is few spikes, around 7 to 8 spikes of cortisol hypersecretion, which is interspersed between 3 or 2 hours apart. This is called which occurs within 24 hours of time. This is the ultradian rhythm. And there is one more rhythm called the infradian rhythm. In infradian rhythm, the duration is about weeks to months, where the amplitude of cortisol is very less. But it has been seen that both the ultradian, infradian, and the diurnal rhythm all are mainly regulated by both CRH and ACTH. In Cushing's disease, we all know that this diurnal variation is lost and we get secretion. And typically, this is the secretion in Cushing's disease where the diurnal variation is lost. Now let us come to the definition and the criteria of cyclic Cushing syndrome. Generally, it is accepted that to define a patient to be having a cyclical Cushing, the patient must have 3 peaks of hypercortisolemia and 2 troughs. Now, if you see, many patients have cycles of short duration from days or months, but patients are also there, reported patients are there where in 5 years, patient can have 2 peaks. So it becomes very actually difficult to diagnose cases of cyclical Cushing's with this definition. But then this is what we define: 3 peaks and 2 troughs. Cyclical Cushing is also described by some other names. There are some other description of this, like some say it is a periodic hormonogenesis or unpredictable hypersecretion of cortisol, or fluctuating cortisol, steroid excretion, or intermittent Cushing syndrome. Now, Shapiro et al. Studied 44 cases of cyclical Cushing's, and to see the pattern of cyclical cortisol overproduction, and they defined or they grouped these 44 patients into 4 categories. Actually, these are not classification. This is just one article which I took from Quarterly Journal of Medicine, where they described 4 categories of cyclical Cushing's. In one, there was regular cyclical hormonogenesis with non-variable clinical expression, which they termed it as periodic hormonogenesis. Second category, there was regular cyclic hormonogenesis with periodic classical or clinical expression. And the third category they described was irregular cyclic hormonogenesis with corresponding clinical signs and symptoms. This they termed as intermittent Cushing syndrome. And irregular cyclical hormonogenesis with constant clinical manifestation. So you can appreciate that this cortisol secretion can be very variable in some patient. It is not always very predictable to have, if the patient has cyclical Cushing's, it is not always predictable that every 3 months, 2 months, or every some days or years you'll have this features of Cushing's. Not in all, but in some it happens. Now let us come to the prevalence of Cushing's, cyclical Cushing's. As a whole, you know, the Cushing syndrome is hardly 2 to 3 cases per million per year incidence. So cyclical Cushing's is even less. We do not have any prospective data like to define or to find cyclical Cushing's, but I found this article published in European Journal of Endocrinology, where they describe the prevalence and clinical features of cyclical Cushing. So they studied about 201 patients, of which 30 had cyclicity or variability. They defined cyclicity on some criteria, and it was about 40.9%. So nearly 15% of confirmed Cushing syndrome, 201 such cases, 15% showed some cyclicity. As in any other endocrine disease, female population was was more common. Some 86% were having cyclical Cushing's, and even pediatric patients were showed cyclicity. Second case was also an infant for the first time when she showed cyclicity. This was a big study, but then there are also some small studies like McCain et al., where he evaluated serum cortisol levels in 41 patients with Cushing's disease who underwent transvenereal surgery, and cyclic cortisol production appeared to be present in 17% of them. Another study by Strittin and co-workers in 31 patients with Cushing's disease found that 19% had some amount of cyclicity. And Atkinson et al. Followed 14 patients of Cushing's syndrome over a long period, 2 years, by frequent cortisol measurement, and he documented that 36% patient had this cyclicity. So overall, if these data suggest that cyclic cortisol production is present in about 20 to 40% of patients of Cushing's syndrome, and this is actually quite a big number. And very often we actually do not suspect or the cyclicity, or whenever there is a florid case, we diagnose and treat. Now, what is the etiology? We all know that Cushing's syndrome, we divide it into two groups, mainly ACTH dependent and ACTH independent cases. Cyclic Cushing's also follows almost a similar type of pattern. Here also, I have taken this article from European Journal of Endocrinology, where 65 cases of cyclical Cushing's were analyzed for the etiology. And it was found that overall, ACTH dependent Cushing's was 80%, of which pituitary dependent or pituitary ACTH dependent was more than 50% of the cases, and rest ectopic. Carcinoids from thymus, from bronchus, from pancreas, even from gastric carcinoid, all these cases have been shown to cause cyclical Cushing's. Even adrenal lesions, 11% overall adrenal cases also showed cyclicity. And in some 9%, they could not classify the cause. So you can see that cyclical Cushing's, it follows the typical etiological causes of Cushing syndrome only. Now let us come to the next important part, that is, what is the pathophysiology of cyclical Cushing. Now, though there is no definite, exactly the definite cause or definite pathophysiology has yet not been described, but some pathogenic mechanisms has been described in literature. One is that it is proposed that episodic hemorrhage and synchronic growth and rate of ACTH or cortisol producing tumor cells may lead to periodic hypercortisolism. So as it suggests that there may be some hemorrhage in this existing pituitary adenoma, there may be some which can cause suppression of cortisol secretion, thereby the TRAbs, and again some synchronic growth which may result in peak. So this was supported by some studies where after histopathology was done, necrotic areas were described in pituitary adenomas, but it was not universal. Some patients had, some patients didn't have. Moreover, there was one case which was described to be having, of case of cyclical Cushing, to be having pituitary stone. Pituitary stone means we can presume that this patient had pituitary adenoma, and where some infarct might have occurred, and then it was calcified. So this stone is nothing but calcified area of necrosis. But other authors, they do not digest this fact that there will be synchronic periodic growth of a pituitary adenoma, and then again there will be death of this ACTH or producing cells in a very cyclical manner. Now, second mechanism which is proposed is that persistence of negative feedback control of tumoral ACTH secretion by cortisol in cyclic Cushing syndrome. Now, this idea came from description of a patient. This was a case of carcinoid syndrome. It was a bronchial carcinoid syndrome. The patient was having cyclical Cushing's, and this patient underwent bilateral adrenalectomy. Now, what happened was, before diagnosis, the ACTH level was some 200, at the range of 200 picogram per ml, and cortisol was obviously high. And it was seen that after the bilateral adrenalectomy, the ACTH level shoot up to 3000. So from 200 before surgery, after the surgery, it increased to 3000. And when this case was followed up over 2 years or so, that ACTH level did come down, but it remained higher still. It was before the surgery, it was 200. After at 2 years, it remained at around 400 or around 300 or 400. This is well explained. So here, after this case was described, this mechanism was proposed that the cortisol was suppressing the ACTH secretion. Third theory is it is related to the Cushing's disease only, and it proposes a hypothalamic origin. So they say that cyclicity is because of some problem with the hypothalamus, and there are neurotransmitters such as CRH, noradrenaline, and GABA. So these can influence the hypothalamus and cause cyclicity. And it has been seen that in cyclical Cushing's, treatment by sodium valproate ameliorates the symptoms. And we all know that sodium valproate is a GABA agonist, and GABA is known to reduce the CRH level without influencing the ACTH level. So retrospectively, it is proposed that GABA and all can influence the hypothalamus, and thereby they can cause cyclicity. Another proposal is that central dopaminergic tone, some changes in it may be also responsible for cyclical Cushing's disease. If we consider this, then it has been seen that dopaminergic agonistic drugs like bromocriptine can ameliorate some cases of cyclical Cushing's disease. Another proposal is that hypothalamic serotonin production might be involved in the development of cyclical Cushing's disease. And cyproheptadine, which influences serotonin, has been also shown to somewhat influence cyclic Cushing's disease state. So these are actually proposed mechanisms, though exact cause is yet to be found. Now, what is the clinical characteristic? Basically, cyclical Cushing syndrome doesn't have any typical features from where we can just identify that, oh no, this patient will be having cyclical Cushing. When they are florid, then they will have the typical features of Cushing syndrome. And however, there are patients who may not have any features. Like our first case, he had only proximal muscle weakness and hyperpigmentation, but then typical Cushingoid feature was not there. Now, this data was written from again European Journal of Endocrinology, 2009. This 65 cases were reported, and the authors tried to find out what are the clinical characteristics of these 65 patients with cyclical Cushing's. So overall, there was females were more in number, 72%, and age of onset varied between 0 to 72. The eldest patient was 72-year-old. And if we see here, the Cushing's feature was present in about 94% of the patient. Pituitary cases, because they divided again these patients to be having pituitary cases, ectopic ACTH, and adrenal case. The typical Cushing features were more prevalent in patients who had pituitary disease than in patients having adrenal disease. Also, they found that diabetes mellitus or glucose intolerance was present in almost 1/3 of the patient overall, and which is more common in ectopic ACTH patient. Mood disorders were also significantly noted in about 23% of the patients, and in females, there was amenorrhea in 13% of the patients. Overall, when they followed up this patient, then they found that the cycle length, overall the cycle length was about 21 days, and intercyclic phase was about 30 days. And overall, the survival percentage was 94. But in one other article, I could find that in cyclical Cushing's, the survival rate was slightly lower than if you say non-cyclical cases. So now let us come to the differential diagnosis of cyclical Cushing syndrome. How to differentiate and what are the conditions which come to our mind when we think of cyclical Cushing's. Number one is the pseudo-Cushing state. Now, pseudo-Cushing state, as we all know, it is characterized by a clinical picture which resembles a true Cushing syndrome with biochemical abnormalities, which resolves after the resolution of underlying non-endocrine cause, and depression, alcohol use, these are simple obesity. These are the causes of pseudo-Cushing syndrome. In such patients, we can combine a 2 mg dexamethasone CRH test to differentiate between depression and Cushing syndrome. But then this it is very difficult to differentiate cyclic at all. First, we have to think of cyclical Cushing's. To think of cyclical Cushing's itself is you need a lot of okay. Now let us come to other differential diagnosis. Another is the mild or subclinical Cushing syndrome. Now we all know what is subclinical Cushing syndrome because of now it is because of increased use of radiology. This incidentaloma, adrenal incidentaloma are diagnosed more easily or more frequently, which may be secreting very less amount of cortisol, not sufficient to cause typical features of Cushing syndrome, but biochemically they may have evidence of Cushing syndrome. This is one differential diagnosis. Another is aberrant receptor-mediated Cushing syndrome. Now, it has been seen in rare cases that cyclical Cushing may be present or may result due to presence of some aberrant adrenal receptor. Like a case has been described who had Cushing's like features or Cushing syndrome during pregnancy. She had 4 pregnancy, and each time she developed this Cushing syndrome like features, and then after delivery it automatically resolved, and this probably is because of aberrant adrenal LH receptor expression. There is also an entity called food-dependent Cushing syndrome. Actually, this is not a true Cushing syndrome. Here, because of ectopic expression of receptors like GIP, after intake of food, there is increased secretion of cortisol. So here, typical feature of Cushing syndrome is not seen, and very often in the morning hour, in fasting state, the cortisol level remains normal, which rapidly increases after intake of food. Another condition is the factitious Cushing syndrome. Very often, patients they take like steroids, and they present as Cushing syndrome, as factitious Cushing syndrome. And when such factitious Cushing syndrome are suspected, we have to specifically measure the urinary cortisol level using the GCMS. And this very often helps to distinguish the true Cushing syndrome from those induced by synthetic glucocorticoids. And moreover, we have to also note that endogenous cortisol overproduction due to cyclic Cushing is accompanied by also elevated urinary levels of cortisol metabolites. Another differential diagnosis of cyclical Cushing's is glucocorticoid resistance. Patients do not have any typical Cushingoid appearance, but patients have both high free cortisol excretion and serum cortisol levels. But the circadian rhythm is preserved here. Now, how do we evaluate a case of Cushing syndrome, cyclical variety? So evaluation is basically same as what we follow, the different tests we use. It includes 24 hours urinary free cortisol, and the cutoff values, it depends on the laboratory and assay method used. Then we can use the low dose overnight DEXA separation test, the late night salivary cortisol test, and 2-day low dose DEXA separation test. Even we can do a late night serum cortisol whenever there is a suspicion of hypercortisolemia. Now, besides this, to rule out like pseudo Cushing's, we can use 2-day LDDST with consecutive CRH test. And one particular test which I could find was the hair cortisol level, uh, which is probably useful in cyclical hypercortisolemia. Now, what is this hair cortisol level? Hair cortisol level is a novel tool which might be helpful for establishing the diagnosis of cyclical Cushing. Now, it has been seen that when cortisol is secreted, it gets deposited also. It can be estimated in the hair, and hair can be used to create a retrospective timeline of cortisol exposure. And it is said that for every 1 centimeter of hair, it corresponds to the cortisol level of 1 month. So if a person's hair, say about 10 centimeter is taken, for every 1 centimeter, so 10 centimeter for last 10 months, we can find the cortisol level in the hair. So this is a very new and novel tool where the measurement of cortisol level in scalp hair, and this is currently the only method which provides information on cortisol exposure in previous months to years, and this probably is very valuable in patients suspected to have cyclical Cushing's. Now, to find out the origin of the hypercortisolemia, again we do the typical test, the morning AC test, to define whether it is ACTH dependent or ACTH independent. Then follow other tests if required. These are same. Only thing is we have to have suspicion that this patient is having Cushing syndrome. Now, this is a flow chart actually. This I took from a journal published very recently in the Frontier of Endocrinology. So they have described this flow chart. This is not from any society guidelines. Here, if there is any clinical suspicion of hypercortisolemia, after excluding the exogenous hypercortisolemia, we should initiate tests for Cushing syndrome. These are the first line tests, as we all know, and both UFC and salivary cortisol, at least 2 tests should be done. And second test includes, if required, late night serum cortisol, and if required, you can do a 2-day LDDST plus CRS test. Now, here with this test, intermittent neoplastic hypercortisolemia cannot be excluded by normal result of this test. And in case of clinical suspicion of intermittent hypercortisolemia and symptoms with variability in signs and symptoms, periods of relapse and remission, further diagnostic methods are actually required. And the most important part is patient education, that they should be counseled that whenever they have typical features of Cushing, they should come, and we should focus more on the repeated assessment of urinary free cortisol or salivary cortisol. Now, if we do if we continue this flow chart, like, so if after repeated assessment, if results are positive, then we can do the radiological testing to find the cause of the cyclical Cushing's. If not, then we should ensure that tests are done during the relapses. And when there is clinically overt phase, these are the tests which we can do, as already I have described. If results still remain ambiguous, if the results are positive, then again we do radiological testing. But if still results remain negative or ambiguous, then probably we can go for scalp hair cortisol or maybe the desmopatient stimulation test. So this is a flow chart for cyclical Cushing. Now, how do we treat cyclical Cushing? The treatment of cyclical Cushing is not different from that of the standard Cushing syndrome once the diagnosis is made, because the etiology, as we have seen, the most common cause is the ACTH-dependent pituitary adenoma. So treatment of pituitary adenoma, we all know the surgery. Then ectopic ACTH, the cause, and the treatment will be as per the cause of the cyclical Cushing's. So to conclude, I would say that cyclical Cushing syndrome is rare. Overall, its prevalence is less, but it is well defined and probably underreported entity, which poses a greater than usual diagnostic challenge. Clinicians should be aware that hypercortisolism could manifest in a periodic fashion. Cyclical Cushing syndrome can be due to both adrenocorticotropic hormone dependent and independent causes, and always we should be careful to rule out any differential diagnosis. Cyclical Cushing syndrome should also be considered in patients with any intermittent or periodic symptoms or signs and findings such as intermittent or periodic muscle weakness, edema, hypertension. Very often, patients come with non-specific complaints that these days I am having this muscle ache, that we get swelling of the legs, and then it goes off just like that. Very often we ignore this, but then we should always keep in mind that that patient may be suffering from cyclical Cushing's. And to actually come to a diagnosis, we may require repeated investigation. Repeated late night salivary cortisol level is easy because other tests like urinary free cortisol, it is cumbersome also, but repeated late night salivary cortisol level should be measured to establish the clinical, or sorry, the cyclical nature of excess cortisol production. And that ends my deliberation. Thank you, all of you. So I end here, sir.
Yeah. So yes. I think it was a really good talk. It was a deliberation which was exhaustive. It was encompassing every aspect of cyclical Cushing, right from how they present, how do you find different differential diagnosis for that, how difficult it is to even think of them, and the details of how to investigate these patients, especially with repeated tests and the tests which have more of kind of some sensitive test as well as specific test as and where is required depending on the type of the patient which has been seen. Definitely the management issues with that and the treatment. So things become quite simple once you really suspect it, and if you find a cause for it, then the treatment becomes simple. But the most important part for cyclic Cushing's is to really suspect it and diagnose it rightly, and that's where I think the major thrust has been laid on. I think you've done a great job, complete in-depth review of everything. So I think we throw open this platform to questions from students or anyone, and then maybe we take it further from there.
Yes.
Do we have any questions?
Yes, there is one question in the chat box. If the CRH is not available, then how to rule out the pseudo Cushing's?
If pardon what?
If the CRH is not available, then how to rule out the pseudo Cushing's?
Yes, actually, this the LDDST CRH stimulation test. Actually, though we read it in theoretically, CRH actually it's not available, so we cannot do this test. But in some literature have clearly shown that LDDST is a LDDST in most of the time it very clearly differentiates between pseudo Cushing's and actually true Cushing's. LDDST has high sensitivity because in Cushing syndrome, the set point is only slightly increased, and it is not completely, the inhibition is not completely gone. So I think though it is difficult, LDDST is a good tool.
Yes, I completely agree with it.
Yeah.
We've been using LDDST to the advantage and to rule out pseudo Cushing syndrome, because other tests may not be really good to give you the specificity of the diagnosis of pseudo Cushing's. Or your UFC is not going to work properly, ODS is not going to work, and salivary cortisols, everything. It's a state of hypercortisolemia which gets suppressed with LDDS. Practically, we have not had much issues, but we've used LDDS CRH also, where we have picked up milder Cushing's who present like a pseudo Cushing's. So, I mean, we can say that.
Yes, sir. The second question is, what are the cutoff used for the urinary free cortisol for various conditions?
Actually, it depends on the assay and the test used. It depends on the laboratory. We use the from the laboratory cutoff points only. Is there any specific like, there is not a universal specific cutoffs like for UFC. You have to depend on the assay used and the methods used. So the lab values will be there. You use that cutoff.
Yes, sir. There are no more questions in the chat box, sir. Actually, sir, it was really fascinating session with in-depth detail of the cyclic Cushing syndrome, sir. I would like to thank Dr. Tushar, sir, and Dr. Bipul Chowdhury, sir, for giving us valuable time for this session, sir. And for the small reminder for the next program, that is the interventional radiology in the endocrine practice by Sarvesh Tiwari, sir. He is the assistant professor in the AIMS Jodhpur, sir. Sir. Final concluding remark from Tushar, sir. Sir.
Yeah, sure. So I think, as I said earlier, it was completely exhaustive talk. I would just want to make one or two points. One is definitely, as has been said earlier, that if the patient comes with atypical symptoms, and if you suspect, please look for cyclical Cushing. Especially now, the most common cause of Cushing's is exogenous Cushing syndrome, where patient comes with low cortisol levels, and so we need to keep our eyes open in that subgroup of patients where, if you think of cyclical Cushing's who presents with with adrenal insufficiency, you may pick up some cases from there. That's one clinical message I would want to share. And the other one, whenever you would want to evaluate a patient for confirmation of diagnosis, you need to have a hypercortisolemia there at place. And whenever you want to differentiate it further by either an IPSS or other test, then we need to have a cortisol level documented on the day of IPSS to say whether you can differentiate between the cause of Cushing's, especially in those with cyclical Cushing's, because if you don't have a cortisol level done on the day of IPSS, you may fall in soup regarding the diagnosis. So as a practice, when we do IPSS also in all our patients, we do cortisol level on the day of procedure, or at least a day before, to show that the patient is in hypercortisolemic state.
Very true.
I think that's what is the message. Rest all has been very well covered. I would like to stop here.
Thanks, sir, once again for that very in detail talk, and thank you, Tushar, sir, for your valuable time. Sir, we will conclude the program here, sir. Thank you very much.
Thank you.
Thank you. Bye. Good night to all of you.
Good night, sir.